repair, I would still supplement it with a semi-constrained prosthesis like a PC3.
Yeah, well, I didn't have that. I put in a posterior stabilizer, did a good repair, and put her in plaster for 6 weeks, and she actually did tighten up.
Sometimes you don't have a constraint on the shelf. That's the issue. And when you do this, you get...
Yeah, I only had a posterior stabilizer. Very embarrassing. Any other questions? If not, we can move on. Okay, good.
Thanks, John. Couple of housekeeping announcements. Mobiles on silent, please. And if you need to talk, you need to go out because it can be disturbing. And even if you need to talk otherwise, maybe 2 of you need to go out. And the point is that, why deprive the others? The next speaker is going to be my friend Ajay Gupta, who has actually helped put this symposium together. He's in UK, but at heart he's very much Indian, belong to the same city, perhaps we're born in the same city, and he's creating the new route, the equivalent of Silk Route back from the UK to India as far as orthopedics is concerned, and he's trying to work on affordable health. For you to bring that in, and we will have him speak on a very crucial topic. You get this wrong. Mind you, these 3 topics are terribly important, what you've heard. After that is going to be straightforward, just putting the things in. You don't plan what are the kinematics you're following. Believe me, however good your cementing technique or however expensive your implant may be, you still be in trouble. So Ajay, if I could request you to please, kinematics of the knee.
Thank you very much, Sanjeev. Well, it's a great honor to be here today. It's like homecoming for me. I'm of course very grateful to my British colleagues for traveling the extra distance to India. Okay, for the next 20 minutes I'm going to talk about kinematics of the knee, a very complex subject, could be boring to a few, but I think it's very important. So what's kinematics? It's a branch of mechanics that deals with pure motion without reference to the forces involved in it. The question is, why do we want to know kinematics as surgeons? Well, if you look at the results of total knee arthroplasty, 3 important factors are patient factors, implant design, and surgical techniques. Well, over the next 15-20 minutes, I'll talk on 2 of these, the implant design and surgical techniques, and understand how we can make our surgical results better. And I think, as Sanjeev said, 52% of our patients report limitation in the functional activities, and we surgeons seem to be happy with the results than the patients are. So does total knee replacement restore normal function? Well, clearly not. There's a John Insull Award paper published in 2005 which confirmed that improvements in procedure and prosthetic designs are still needed. So if you come on to the anatomy of the femur, we've got 2 condyles, the medial and the lateral. They're joined by the femoral trochlea anteriorly and separated by the intercondylar notch posteriorly. But what I bring to notice for you is the fact that the medial and the lateral femoral condyles have different sagittal radius, which means that the flexion radius and the extension radius are different, a concept which is used for the multi-radius design knees. If you come on to the anatomy of the tibia, as Chim referred to, the articular surface is normally about 3 degrees of varus relative to the long axis. That's because the lateral tibial plateau is higher than the medial. If you look at the sagittal view, the articular surface is about 0 to 5 degrees posteriorly sloped. I think this is important when we make our proximal tibial cuts because some implants are inbuilt with a posterior slope while most of them are neutral. Looking at the anatomy of the patella, we know that the patella is intrinsically unstable. That's because the line of pull of the quadriceps is laterally. The Q angle is normally 12 to 15 degrees. You come on to the anatomy of the cruciates. Well, ACL is the primary restraint to the anterior tibial translation. It facilitates the screw home mechanism, which is 15 to 20 degrees of penetration in the last few degrees. The posterior cruciate acts as the primary restraint to the posterior tibial translation. Again, bring to your notice the fact that PCL tends to insert 1.5 centimeter distal to the joint line, and this is important in cruciate retaining knees. So if our tibial cut tends to go below 1.5 centimeter, I think idea is to switch on to a posterior sacrificing knee intraoperatively. So if you think of the evolution of kinematics, we had the four-bar cruciate linkage system, 1900s to 1990, talked about the four-bar linkage between the PCL, the ACL, the tibial and the femoral bony links. This of course was a two-dimensional model which had assumed isometricity only in passive movements, and how has now been given away as the kinematics evolved over the years. We gradually got onto the femoral rollback, which was as the knee flexes, the femur rolls back on the tibia, increasing the potential for further flexion but preventing posterior structures from impingement. This is what the later concept was, and we've got two models there of the posterior stabilizing and the cruciate retaining knees. The new concept is the four-bar link model is wrong. The concepts of femoral rollback constraints need to be revised. We know that the knee is asymmetrically stable. The medial compartment is more stable than the lateral. The prevailing concept that brings us to a medial pivot knee. We've got a study which focused on tibiofemoral movements, full flexion in the living knee studied by an MRI. So if you look at the functional analysis of a lateral and a medial compartment, and you separate the two together. So you got the lateral compartment which flexes by combining of rolling and sliding, and you got the medial compartment that moves by sliding to deflection. So I'll repeat that. So the medial compartment moves by sliding deflection, whereas the lateral compartment flexes by combination of rolling and sliding. And this is possible only due to the shape of the articular surfaces. Brought us to the concept of medial pivot. The other concept in kinematics is the multi-radii design. We know the most contemporary femoral components have sagittal geometry of a natural femoral condyle, which has two different radii, a large radius of the R1, which contacts the tibial plateau near extension, and a smaller radius of R2 that contacts it in flexion, as shown there. However, we do have now got the anatomical radius design, which is a single radius, which ensures ligament of isometricity and replicates the knee motion. I think the concept behind this is to have the radius along the center of the ligament insertion onto the proximal tibia and the femur. So what's the difference between PCL retaining and substituting? We've talked about this before. It's an ongoing discussion. We know that the PCL retaining processes gives us better range of movement, both in terms of rollback of flat tibial surface, gives us a better or more symmetrical gait, is less femoral bone section is required. However, we've got to be accurate about its placement, especially during the pull-out or lift-up test. In contrast, the PCL substituting processes allows easier surgical access, easier correction deformity, but has complications in the form of peg wear or increased bone sacrifice, and increased flexion gap. So what do I do in my practice? Well, I tend to use posterior substituting knees in the following conditions: whether it's a stiff ankylosed knee, or a patient has had a previous patelectomy, or a distorted joint line post osteotomy, or a PCL rupture, normally degenerative. A patient has had a valgus deformity or a varus more than 20 degrees, or if he's got a severe flexion contracture. I think my practice is to use a cruciate retaining in all of the conditions. So what are the technical goals of total knee replacement with respect to kinematics? Well, we want to restore the mechanical alignment, something we've mentioned that before. We want to obtain the normal rotation of components. We want to balance the flexion extension gaps, and of course maintain the Q angle we mentioned before. And we must respect all these biomechanical principles to achieve our goals. So coming on to the normal limb alignment, we've got the mechanical axis, which is shown there between the center of the head of femur, center of knee and the ankle, and we got the anatomical axis. And as Chim Gupta mentioned, the normal angle between the two is 6 to 9 degrees, and we tend to put a femoral component in 5 to 7 degrees of valgus in relation to the anatomical axis. The anatomical axis is the one in which our intermediate device goes. The tibial components are, however, implanted perpendicular to the anatomical axis, which is the same as the mechanical axis for tibia. So what's the dominant rotation alignment and why do we need that? Well, it brings us patellar tracking, it decreases the component wear, causes less tibial loosening, and allows us ligament balancing. And how do we rotate our components? Well, we use the gap technique. Idea is to have a flexion gap which is equal to extension gap. The flexion gap, as you all know, is a gap between the posterior femur there and the proximal tibia. And the extension gap is between the distal femur and the proximal tibia. So normally the femoral component is in about 3 degrees of external rotation, and the idea is to achieve the stability and the flexion gap balancing. The tibial component is normally placed in neutral rotation. So how do we get our components in the right rotation? Well, in terms of femoral component, we've got 3 different axes. I think 2 of them have been mentioned. We've had a description of the posterior condyle axis, which is a line joining the 2 condyles posteriorly. We've also talked about trans-epicondyle axis, which is the axis between the 2 epicondyles. And we've talked about Leo-Whiteside line, a line perpendicular to the axis trans-epicondyle. You could use any of these, and I tend to use the trans-epicondyle axis in most of our patients. In patients with valgus knees or with posterior deficient femoral condyles laterally, it's important to use the Whiteside line because the posterior condyle axis is almost gone. In terms of the tibial rotation, I think the rotation is new. Of course, we want to have a neutral rotation. We can use any of the 4 methods. We can use either the posterior lateral corner to be exposed and align a tibial component according to that, or have it aligned with the 2/3 of the tibial tubercle lateral to the component, or even use the drop rods or the ankle mortise technique. Of course, what I tend to use is a combination of these and also a self-alignment of the tibial component, which means once you've put the inserts in, you take them through a range of movement and then align, let the tibia align itself and mark it with the diathermy. So what are the effects of malrotation? What if you get your femoral rotation beyond 3 degrees external rotation or internal rotation? Or if you get tibia internally externally rotated? Well, it destroys the kinematics of the joint and leads to earlier loosening. I think the idea is to never internally rotate the femoral component, and that's especially in valgus knees, in which we use the trans-epicondyle axis. And malrotation of a femoral component may lead to patellofemoral dislocation or subluxation, as shown. The same arises for the internal rotation of tibial processes, that increases the Q angle, and medialization of tibia also increases the Q angle. So once you've got your flexion extension gaps, you know the ligaments are of the same length at all degrees of flexion, whether it's flexion, extension, or mid-flexion. And you've got to balance the gaps both in flexion and in extension. So you now got 4 scenarios. Okay, we've got a patient in which we've got tight flexion and we've got tight extension. So what do you think we should do in this? What will the house think? What should we do if we've got a knee intraoperatively when it's tight in flexion and extension?
We can increase the posterior slope.
Yes, we could increase the posterior slope of tibia, yes. So because the flexion gap and the extension gap, they both are tight, is the proximal tibia, because the proximal tibia compensates both of them. So you could decrease the proximal tibia, take off more of the proximal tibia as you mentioned. What if it's tight in flexion and loose in extension? So you've got a scenario in which the knee is tight in flexion, but if you bring it back to extension, it's loose. Yes, so you can take off more of the posterior or built up with the tibia. What if we've got loose in flexion and tight in extension? So it's the other scenario. What would you do then?
We can augment the posterior.
Yes, absolutely right. You can increase the size of the femoral component to build up the flexion gap. And finally, we've got loose in flexion and loose in extension. What would you do then? Yes, absolutely right. Increase the tibial space, put a spacer in, because tibia contributes both to flexion and extension. Okay, I have a brief mention about posterior condylar offset. It's a new concept. I'm sure most of you have heard of this. It's a concept which is brought about by Bellman et al. Talks about delivering powerful function using either the quadriceps lever arm or posterior condylar offset in our total knee replacements. So what's a posterior condylar offset? It's the distance between the posterior condyle of femur there and the posterior cortex of femur. So that distance is the posterior condylar offset. Now clearly if you have a larger distance there, the knee flexes more. And studies have shown that if you reduce the posterior condyle offset, so if you decrease the distance between the cortex there and the condyles there, that decreases the flexion, the potential range of flexion. For every 2 millimeters in decrease in the posterior condyle offset, the flexion can reduce by 12 degrees. So that's a very big figure there for decreasing your flexion if you decrease the posterior condyle offset. So what are the common causes of decreasing the posterior condyle offset? Well, if you make the interior cuts too anterior, so you got too far anterior, so you decrease the cap there, and therefore you prevented the tibia from going back too far. If that distance has gone down, the knee can't flex as far. Of course, what you want to do is increase the posterior condyle offset by restoring your joint line. And this was proved and published by Bellman et al. In 2002. So in summary, we've talked about femoral rollback, the evolution of kinematics. We've also talked about single radius and the multi-radia designs. We've briefly mentioned about the posterior retaining or the sacrificing knees, and the jury is out. You could do either, except if it's a valgus knee or a mid-flexion instability, or if you're definite that the piece is degenerative and gone. The femoral component rotation should be in 3 degrees of external rotation. We can use either of the 3 indices. We can use the posterior condyle axis, or the transepicondylar axis, or the Leo-Weitzel line. The tibial component rotation has to be neutral. We could use either of the 4 methods that I described earlier. I think the best one would be a freely range of movement exercise. And of course, we could have either interior or posterior referencing surgical techniques. And we've briefly mentioned about posterior condyle offset. And finally, I think it's important that we as surgeons are not confident and take our surgery seriously till we achieve the end result. You've got a cyclist there. Yeah. Thank you very much.
Thanks, Ajay. Any questions on this? Ajay, what intrigues me is why do they calculate that for every 2 degrees it is 12? Why not for every 1 degree it is 6? No, I mean, what if it is 3? It just comes to mind because normally you go by unitary method, or it's not. I mean, it's just a curiosity. It's not trying to.
I have a question on that. This posterior condylar offset issue. Yeah, I think it's an extremely important issue to address. If not at the basic fundamental, maybe at some other forum. But so if you allow me, I just want to.
Go ahead.
The fact is that Johann Bellman has taken an assumption that when a knee goes into flexion, it doesn't roll back, and therefore the posterior lip of the tibia might hit at some point the posterior cortex of the femur, and therefore the higher the offset, the more the flexion that is allowed. This is the basic presumption that Johann Bellman is putting at play. Whereas Pinskarova and Michael Freeman's studies are very elegantly shown in the concept of the medial pivot knee, that when flexion happens in the human native knee, the lateral femoral condyle actually not only just rolls back, but almost slips off the edge of the posterior edge of the tibia. The moment you put this into your conceptual equation, the offset has no significance. The offset has a significance only until you stick to the idea that there is no femoral rollback happening in the knee. Whereas the fact of the matter is that a femoral rollback does happen. Somehow Johann Bellman's paper has taken so much prominence in basic meetings and in everywhere across the world that this particular fact is lost. And this is very relevant to parts like ours in the world, in India and in Asia, where thigh flexion is extremely important part of routine day-to-day activities for the population. It's about as important as a Western Caucasian population being told whether you'll be able to get off a chair or not after a knee replacement. And we have thousands and thousands and thousands of cases now. We have patients going into good flexion, pre and post-op, despite the femoral offsets not being very dramatic or say 4 or 5 millimeters, which theoretically should be required if Bellman was taken at its face value. You know?
So that's an extremely important point, I think, that all of us need to internalize.
You want to ask something?
So I actually just wanted to say something that when the TKR started its development, initially they tried to mimic the natural anatomy. Then this concept came wherein Insal came with the total condylar concept, the knee. And now again they are going with the natural knee concept with the medial pivot shift design. So till we are using this condylar concept, I think PCOs will have a significance. When we shift to the medial pivot designs for the knee, then maybe the advantage of the condylar offset might go, sir. Right now, if we are using the knees with the implant design has to be, we have to balance the posterior condylar offset. Right now, we are using those implants.
Absolutely. As we discussed the evolution of the knee design, you got the femoral and forearm limitation, and then you got the middle pivot. Clearly, now new designs in London.
Now this medial pivot is becoming more and more common.
I'll address that in my next lecture. It's all about
Selection of implants, and that addresses very clearly the implications of the implant design on the flexion issue as well as the posterior condylar offset.
Right. We will let him come up for the next topic, which is selection of implant. I had an observation, but I'll make it on the sacrificing versus retaining implant. I'll make it after your talk if there's any need left. And also let me introduce Bharat Modi. He is a very shy man outside. You'll just walk past him and you won't even recognize him, but he can be considerably dangerous when he is scientific. And he is the future president of Indian Arthroplasty Association and a great friend. Bharat, let's hear you. So try and cover what I have to ask.
Thank you.
Gentlemen, it's a pleasure to be here. My claim to fame is that I have friends like Sanjeev Madhya, and now I would say Ajay and so many others, John, Chinmay. It's an absolute pleasure to have heard you this morning. Let's start here. Decision making in implant selection in total knee arthroplasty. Primary total knee arthroplasty implants can be classified broadly into the total condylar and the unicondylar. The vast majority of arthroplasties done across the world are the total condylars. If I'm not mistaken, most registry data would indicate that unicondylars are just about 3% of the total arthroplasties done across the world. Total condylar implants have these basic broad sort of groupings. You have the fixed bearing modular PCL retaining, then you have the fixed bearing modular PCL substituting. Within the fixed bearing, you have this modular and then also the monoblock group, wherein you can have two groups, the all poly and the trabecular metal tray, which basically means that the plastic is fused onto the metal side of the implant. In other words, there is no modularity. Then you have the mobile bearing, and then you have these relatively, at the moment, not in much wide usage, but the ceramic components knees and the medial pivot design, which we just referred to. And we'll go through these groups of implants to familiarize ourselves as to the options available to a knee arthroplasty surgeon. So again, let's start with the total condylar. I am not addressing the unicondylar specifically at this moment. We might quickly look at it for a couple of slides at the end of the talk, because this forms the main body of work that all of us will do. Amongst the total condylar, fixed bearing and mobile bearing are the two broad groups that you will come across in your practice as you take your decisions in consultation with your patients as to which implant do you want to put into that patient. In the fixed bearing, you have the modular and the monoblock, and both of these offer the PCL sacrificing and the PCL saving concept. In other words, gentlemen, the range of implants that you have, they fall into different categories, not on a single line of thought. What do I mean by this? You have the mobile bearing and the fixed bearing methodology of dividing implants, and then you also have the PCL retaining and the PCL substituting. So these are two different criteria. You can have a mobile bearing with a PCL substituting, you can have a mobile bearing with a PCL retaining. In other words, you need to first understand what are the different broad parameters on which implants are grouped in the present day scenario. But having understood those concepts, you will be able to make your own logical choice depending upon what convinces you as a scientist in terms of the data and the arguments available. So, decision making involves answering the following three questions. Should I use a PCL retaining or substituting implant? Should I use a fixed or a mobile bearing implant? And should I use a modular or a monoblock implant? Okay. The moment you go for a monoblock choice, obviously the mobile bearing goes out of the window. You can't have a mobile bearing as a concept if you are going to choose a monoblock. But you can still think about this as being either substituting or retaining type of an implant. But these are the three basic questions that you will usually have to address early on in your practice. The PCL retaining prosthesis is what I am trying to first address. As late as 1995, 85% of all total knee arthroplasties performed in the USA use this type of an implant. This is derived from this particular source, Data Monitor. Okay. So the PCL retaining was an extremely popular design in the early days. However, and the reason for this was that in the healthy knee, it was believed that the PCL, in the healthy knee there is no doubt that the PCL improves the quadriceps lever arm and aids femoral rollback. Whether these actions occur after total knee arthroplasty remains controversial. But in those days it was believed that to retain the PCL would naturally offer those aspects of PCL activity which were found in the native knee even after the arthroplasty was done. And therefore, these were the things that were supposed or presumed to be derived in terms of advantages when you used a PCL retaining prosthesis. Increased AP stability, improved proprioception, improved femoral rollback, increased varus valgus stability, increased quadriceps force, and there was this feature about saving some bone because you didn't take out an intercondylar notch, in a retaining sort of a prosthesis. However, this type of prosthesis fell out of favor to some extent for reasons as mentioned here. Some of the theoretical advantages which were seen in the native knee were not seen to be replicated in the total knee arthroplasty. And it was difficult to balance PCL, especially in advanced deformity, either for flexion tightness or looseness. Since 1995, the trends have changed, and in 2001, half the knees performed in USA were now PCL substituting type, and this has kept on gathering momentum. You find that more and more number of surgeons are choosing the PCL substituting design, and I'll give my personal opinion on this in a moment. So now coming to the PCL substituting design, the reasons for this change in trend were, as I just mentioned, that many times you get severe degeneration of the PCL, so it is quite obvious on table that this is not a normal anatomical structure. Okay. Proper tensioning of the PCL is surgically demanding. I'll be addressing this much more specifically as a personal view in a moment. Proper tensioning of PCL function in aiding femoral rollback is extremely unpredictable. And once again, I'll tell you what I mean by this in a moment. Better range of motion was achieved with PCL substituting prosthesis. This is where I would differ a bit from what Ajay just mentioned earlier in his lecture. And now let me see why I would want to recommend PCL substituting as a personal faith and conviction based on whatever data I have internalized over my career to date. Pathologies ranging from minimal deformity to major flexion contractures, including varus valgus deformities, can be treated more predictably with PCL substitution. The purported disadvantages of having to resect more intercondylar bone is considered minimal compared with the advantage of a predictable femoral rollback. So now, let me put forth a plea in favor of PCL substitution based on one fundamental issue that I have understood and which has been reinforced today, listening to Ajay's and Chinmay's lectures earlier today. God made the knee as a single evolving structure in the womb of the organism's mother. Okay. In other words, what do I mean by this? The shape of every human femur and tibia, the collaterals, the ACL, the PCL are custom made for each other. The moment you say that I will replace part of that sculpture with a different dimension, shape, arc of radius, thickness of your metal implant, and yet keep that incredibly complex bundle of fibers called the PCL in the same position that it was, and expect it to behave and deliver just like it did when it was surrounded by all the nuances of that native singular evolution that it underwent when it was created. This is being childish and naive at the very least, and foolish if we were to use some harsh scientific words on this matter. How can you, it is the equivalent of saying that I'll put Julia Roberts' face on Oprah Winfrey's body and believe it to give the same impact that it does when Julia Roberts appears in Pretty Woman with her own body. That's crazy. You cannot have that, and this is seen as surgeons day in and day out. Any surgeon who wants to try out a PCL retaining knee on a consistent basis will come across a situation where the PCL becomes tight at, say, 80 degrees of flexion or 90 degrees, and the tibial tray starts lifting off in the front end. And what does he do, or what is he taught to do when this happens? He's taught that do what is now known euphemistically as PCL sliding maneuver. In other words, you start taking off the fibers of the PCL from the front part, from the anterior part of its attachment onto the intercondylar notch area, for that same amount of sliding, into inverted commas, sliding that he inflicts on the PCL. If he was a knee surgeon doing arthroscopic work, for an ACL injury, he would aggressively recommend ACL reconstruction, saying that ACL is now incompetent, 50% of those fibers are already damaged. But as an arthroplasty surgeon, having endorsed the faith or religion of PCL retention, he creates and inflicts that same amount of injury onto an equally important structure like the PCL, and convinces himself that actually what he has done is substituted God's work by doing it himself in making that PCL a bit longer, a bit relaxed, because that is how it was supposed to be, not acknowledging the fact that it is not what it was supposed to be. He is putting in components which are completely differently designed than the native femoral anatomy was, and therefore it is a futile exercise to expect that a PCL retaining concept can be again and again reproduced on a continuum basis and yet get away with the scientific endorsement of that being a sensible exercise. But that is my view. Of course, you will find an equally aggressive stance being taken by the other half of the fraternity who endorse PCL retention as a religion rather than as science. So here we have these three broad categories of implants that are in front of you, and the fixed bearing all poly monoblock tibia, the fixed bearing metal backed modular tibia, and the mobile bearing rotating platform, probably with a central axial rotation, are the most common implants that you will be offered in your career as you go along becoming an arthroplasty surgeon and more. Evolution of TK implants is probably a good time just now to quickly understand this. All poly monoblock is where the whole journey started in 1974, and then came the modular metal back fixed bearing modular metal back in 89 and the rotating platform in 2001. And at the moment you would find that the all poly monoblock has assumed the stature of a David as compared to the Goliaths of this field in terms of the fixed bearing modular metal back and the rotating platform. Once again, I won't labor this point too much. I personally am a believer of the merits of this David here, the all poly monoblock. But today my job is not to enter into a debate against someone here, but I'll still just give you an overview because it beautifully brings out the science behind this whole issue. Okay, so the evolution of TK implants started in 1970s. The fixed bearing high constraint designs were what it started off with, but this increased the shear forces at the bone cement implant interface, leading to loosening. All right. So high constraint basically means that the femoral component and the tibial components were co-acting quite a lot of it together. In other words, they were well fitting and congruent. Whilst this gave more stability, it also increased the shear force at the bone implant interface. This led to loosening, and therefore the designs then swung to the other end of the pendular swing, and you started getting fixed bearing low constraint design in the 1980s. this basically curved on flat designs, and whilst these reduce the shear on the bone cement interface, what it did do was started creating point loads, unlike in the previous version where the loads, the distribution of stress between the metal and the plastic was distributed over a larger area in the constrained designs, whereas in the low constraint designs they started giving point loads. So early tibial designs were almost uniformly all poly, and they failed mainly because it was early days of this TKA science. People had not yet understood the nuances of the engineering and the material aspects of this problem, and so the surgical technique was poor in terms of soft tissue balancing, the cement technique was not perfect, the component alignments were not as perfect as we do them, or at least not as good as we do them these days, and many other reasons. In particular, it was this implant which gave rise to the birth of the modular tibial component. The University of California Irvine all poly design. It contributed to the development of metal back tibial components. Why? Because these implants were relatively thin, only 5 and 7.5 millimeter thick, had low congruency, and therefore they started showing cold flow deformation and a failure rate of as high as 17.5% early on, between 2 to 8 years. And in the same time frame that this was happening, this paper came out by Bartel and Insol. This paper, gentlemen, was instrumental in giving the push to the metal back theory or the modular concept. Bartel and Insol did a finite element analysis study. Remember, it was not a clinical study, it was just a finite element computer simulation study in which they showed that if the tibial component, the plastic was thin and the subsurface bone, the subchondral bone was osteoporotic, then the plastic would bend. And because the plastic would bend, it would lead to early loosening. And it was this which made them recommend that a metal backing underneath a thin plastic would do a good job of distributing the stress. And whilst this was true, the real reason for this type of implant getting momentum in the fraternity was that it offered the surgeon modularity. In other words, the surgeon had the comfort of knowing that right up to the last minute he can change and keep on titrating the thickness of the tibial plastic, right up to the last moment. It was this comfort of the surgeon rather than the science that made the modular implant very popular. And over a period of years, it has now been realized that actually the plastic damage in the tibia, in the knee, occurs a bit differently than in the hip. In the hip, it is abrasive damage, and therefore it is a totally different mechanism in the knee, where it is subsurface cracking and delamination. In the knee, a thicker the plastic, the more resistant it is to plastic failure in the knee. And therefore, as you now see that almost all companies across the world have changed their insert thickness to a base minimum of actually 8 millimeter, and Zimmer actually gives the base minimum as 10 millimeter as the entry point. So the original premise of thin plastics is now gone, and all poly tibia actually offers you 4 millimeter extra plastic without sacrificing equivalent bone. In that sense, the all poly tibia is the most robust of plastics that you can put in a knee joint, and that's why you would find that it is done by those who understand this science to its complete logical thing. Then of course the material benefits of putting the plastic in a vacuum foil, and nowadays you get this semi-constrained. So gentlemen, when you select your implant, just make sure that it is neither fully constrained nor round on flat, but semi-constrained. And most people do that, and that brings the wear levels down below the safe limit. And the micro motion between the components, when you are selecting your implants, look at the locking mechanism of the tibial tray and the plastic, because backside wear is a very real threat to long-term survival of your implants. As you can see, it can cause a lot of osteolysis, and in mobile bearing knees you need to be aware that there are far more wear areas available on offer, although the highly polished concept that goes with it would make the originators of this design claim that it gives you less wear. But common sense says that there are far more areas for wear creation than in others. And you have all these The kinematic aspects, Ajay has very elegantly looked at the kinematic aspects. What I just submit for your consideration is that any knee which claims that it is coming anywhere near close to kinematics of the native knee or the anatomical knee, the people are just kidding themselves. As he showed very beautifully in that video, that actually the native knee remains more or less stable on the medial side as a pivot, and the lateral side goes right out onto the edge of the tibia. None of the present day knees except the medial pivot designs, which are not yet very prevalent, can claim to have this sort of a movement. So a centralized axis by definition gives you a paradoxical movement. If at all you presume that the artificial knee can actually do what the native knee does, then if the lateral side goes back, the medial side will actually do a paradoxical roll forward. So by definition, a centrally axis mobile knee can never claim to come anywhere near a native knee kinematics. There are certain issues related with the mobile bearing knees. For example, the spin out and the range of reported ranges can be as high as 12%. So surgical technique sensitivity with certain types of implants, the surgeon has to keep in mind, and beginner surgeons would be well advised not to be taken in by industry hype, and instead just stick to just simple modular fixed bearing designs. They are the right way to start off. The mobile bearing designs are something that you take on as you become more and more comfortable with this surgical thing. And there are no, in other words, there are no real advantages that are recommending any particular design head and shoulders about others. But if you look at all those things which have been mentioned in this lecture and more that remains to be mentioned, you will find that any one of these will suit your your palate well. For me, this is the king, because it offers everything that a knee replacement implant has to offer at a very good price indeed. Thank you very much for your attention, gentlemen.
Any questions?
I just want to comment.
Yeah, sure.
Gradually people are getting away from using all four tibias.
You're absolutely right.
Fair enough. Fair enough. You want to say anything in your?
Well, I was at the West Palm Beach ISTA meeting, and two big studies have come out which showed very good results of an all-poly tibia, particularly in the over 75s, for a fantastic cost saving. In fact, so much so we're thinking of maybe looking at introducing it now.
So the good news is that I don't normally see more chairs coming in. We've had 2 rows at least which have been added. And you've just heard another Modi here. India is in the wave of Modis at the moment. And you can see how sure and aggressive they can be. They're the future. But thanks, Bharat. I know you've got to go back. If you have any questions for him, you ask him now. Otherwise, we'll try to cope. But
just let me ask you, why do you say that when you use a all polytibia you require very good soft tissue balancing? You require good soft tissue balancing for any implant that you use. All poly doesn't have any specific reason for a higher level of soft tissue balancing to be achieved. If at all that comment has to be made, then I would say it has to be made for the mobile bearing concept, where a little bit of collateral imbalance can lead to a spin out. So. Oh yes, in every age group, and as I said, that's a topic for an aggressive debate on its own, and I absolutely love to get into that debate. I've done it against Doug Dennis and others, and Buchel himself, Fred Buchel. The fact is that the all poly. Tell me one good reason why the all poly cannot be used in the young. There are adequate number of papers as well, huge number of papers to support that. But give me one good reason that an all poly cannot be used in the young, except a vague understanding that it's less costly and therefore an inferior implant. Okay, but give me one good scientific reason, and I'll be happy to take it on board.
If you are, when you're sizing your tibial component, if you're some in between, do you rather hang over the edge or undersize?
Good question. Yeah. If that's an extremely good question which John has asked, that if you have a tibial, if you are sizing your tibial upper end of the tibia, and if the tibial component that you have chosen is in between two sizes, what I do, John, is that if my bone quality in terms of the medial wear, one thing is certain, always and always would my lateral tibial cortex be covered by my component. Now, bringing to the medial side, in the vast majority of the varus cases where there is a density of bone accruing on the medial side, except in rheumatoid type of cases, if the bone on the medial side is very dense and quite often expanded, then I will size it tiny bit under and shave off that medial debulking. But if it's a rheumatoid knee where the bone is uniformly osteoporotic all across, then I would not mind having a tiny bit of overhang, but getting my tibial component on both the cortices to prevent sinkage later on. Yeah.
I think another crucial thing is that I don't think that anybody can do all primary knee replacements with a retaining implant, but you can do all of them, primary ones, with a sacrificing implant. So if you are a beginner, you want some forgiveness, you want simple inventory, you don't have multiple sets like some people who are privileged, then I think perhaps a sacrificing implant to start with is what we have to consider, and it can be a very forgiving implant too, and a couple of millimeters here or there, but not beyond that. But anyway, I think we have all earned a quick cup of tea. 11 o'clock sharp we are back with the correction of deformities. Thank you.
Sanjeev. Well, I think I'm now going to talk about the surgical management of deformity, following on from the previous kinematics talk. Well, we have three deformities that we very common incur in our clinical practice: a varus knee, a valgus knee, and a fixed flexion deformity. So I think over the next 20-25 minutes, we'll focus on each one of these independently. So varus knee. 90% of the knees that we see in our clinical practice, especially in the Asian subgroup, are varus. The commonest cause is osteoarthritis. There's bone loss on the tibia compared to valgus, which is on femur. The MCL is shortened. There's overgrowth of osteophytes on the medial side of the knee. And the lateral ligament complex and capsule are very often stretched. And very often you have the patients walk into the clinic with a lateral thrust. The medial lateral ligament, we all know, is the primary medial stabilizer of the knee. It is deep in superficial layers and has a very broad attachment on the epicondyle. That's a very broad attachment there, expanding onto the tibia. In flexion, the interior fibers are tight, whereas in extension, the posterior fibers are tight there. I think it's important to understand, remember this as we come on to doing releases for a varus knee. So when I come on to ligament balancing, as I talked in the previous talk, it's important to have the flexion and the extension gap balanced and have them equal, symmetrical. Always remove the osteophyte first. Release are normally sequential and selective, and of course we attempt our best not to over-release if we can. So what's the sequence of release? Of course, take out the osteophytes first, post from the femur and the tibia. Focus on the protruding flare of the proximal tibia or the tibial plateau. We've got a sleeve of periosteum and a soft tissue around the proximal tibia which needs to be catered to. We've got the periosteum, the deep MCL, the superficial MCL, the pes, and finally the posterior medial capsule. We tend to do them in controlled phases or stages. The stage 1, you remove the osteophytes and elevate the flap of fibrous capsule. In the stage 2, you extend your exposure posterior medially. In stage 3, address the superficial MCL and extend further down the periosteum. So this is the stage 1. You remove the osteophytes and you elevate the flap of fibrous capsule. So you can take on the osteophytes from the proximal tibia, you've done the femur, and you've gone on to the fibrous capsule. In the second stage, you've extended your incision posterior medially. So you've gone beyond that crest there. Posterior expansion of the deep MCL is adhered and also denuded the medial tibia periosteally. In the third stage is the superficial MCL we address, that's in severe varus deformities, normally beyond 20 degrees, and we extend the exposure down to the superficial, into the periosteum. Sorry. Now, if the knee is tight in extension, again, it's the posterior medial capsule that we talk about, and we release that, the posterior medial deep MCL, or the posterior half of the superficial MCL. If it's tight in flexion, is the interior part of the superficial MCL and the deep anterior MCL. We can also take off or do a precrusting of the PCL or release the PCL from the proximal tibia, as Mr. Modi adhered to before this. So what do you do when you have a condition which you have tight knee both in flexion and extension in a varus knee? Well, you've got to address the posterior medial capsule. You can do the posterior medial deep MCL, the superficial medial collateral, and the PCL. I think all this seems very complex, but the idea is that when you do a varus knee, you do have to do a staged medial release starting from the osteophytes, the deep MCL, posterior medial capsule, and the superficial MCL. We're coming on to a valgus knee. This is a different beast. Why is it different? Well, the unfamiliarity with the deformity, not a very common occurrence. The bony anatomy is different from a varus knee. As I mentioned before, in the varus is the proximal medial tibia that's gone, and in valgus is the distal lateral femoral condyle, which is deficient. We've also got ligament contracture, as we'll talk about. As I said, it's a different beast. We normally have worse results. We have problems with wound healing, stiffness, instability, recurrence of deformity, poor patellar tracking, and this surgical procedure is more demanding. So when do we see rheumatoid valgus knees? We normally see them in patients with rheumatoid, sometimes in osteoarthritis, which is post-traumatic osteoarthritis, especially with fractures around the proximal tibia or distal femur. Well, some could do a lateral approach, as John referred to that in the morning. Advantages are it's more direct. It potentially preserves more of the blood supply to the patella. As you know, the patella blood supply is from the medial side. However, it's more demanding, especially in severe valgus deformities beyond 20 degrees, where you can't very often close the gap. So in the valgus deformity, there are two important anatomical components that we've got to be careful of. One is the lateral bone loss of the distal lateral femoral condyle, which is normally deficient and sclerotic. And we've also got soft tissue contracture laterally. We've got light lateral structures, including the lateral collateral ligament, the iliotibial band, the popliteus, the posterior lateral capsule, and the hamstrings. If you come on to the bony anatomy and you focus on femur, there's excessive wear of the posterior lateral corner or condyle of the femur. So that's the loss in a valgus knee, whereas in the varus is somewhere there. The distal femoral condyle is deficient and sclerotic. And I think we've got to be careful when we use our posterior condylar axis to rotate our femoral components in a valgus knee. Because of the deficient posterior lateral condyle, if you use the PCA or posterior condylar axis as the level or the marker for rotation, you can very often internally rotate the femoral component. And therefore, you got to use either the Leo-Whiteside line or the trans-epicondylar axis. Coming on to the tibia, there's excessive lateral tibial plateau wear. Resection of all defect may result in damage to the lateral or medial structures. In other words, idea is to cut thin to win. In a varus knee, we'll tend to take off about 10 millimeters off the normal side, i.e. the lateral tibial plateau. In a valgus knee, I tend to keep it to about 4 millimeters. So if you come on to the ligament anatomy of a valgus knee, we've got the iliotibial band, the lateral retinacular structures, the vastus lateralis, the popliteus there, the lateral collateral ligament, the biceps, and the patellofemoral ligament there. The iliotibial band has more influence in extension, and the popliteus has more influence in flexion. In other words, if the knee is tight in flexion in a valgus knee, you look at the popliteus to address, and if it's tight in extension, you look at the iliotibial band. Now you got the knee which is tight in extension only in a valgus knee. You release the iliotibial band. That's, I think, is a bit too aggressive. You could do pie crusting of that. You could do a lateral posterior capsule release, and therefore adjust the tibial insert thickness accordingly. If it's tight only in flexion, you can do a lateral collateral ligament release near the femoral insertion, maybe again with pie crusting, or a popliteus release. And if it's tight in both flexion and extension, that's a challenge. If we do either a lateral release or capsule, even iliotibial band with a combination of popliteus and LCL. So what are the different sequence of releases? Well, there are various publications starting from Insall, Runnerworth up to Whiteside and Krakow, and they all have different stages and different steps. So clearly there is no clear indication of the sequence of steps for a lateral release compared to a varus knee. So how do you classify a valgus knee? Well, you got three different types according to Krakow's classification. And I think this is very important because it not only gives us a deformity and calculation, but also an indication to the treatment options. If it's a type 1 valgus, which is less than 10 degrees, it has minimal medial capsular ligamentous sleeve, I could get away with just some medial release, lateral release, and doing a posterior stabilized knee. If it's a type 2 valgus, which is more than 10 degrees, and the stretching of the medial capsular ligament, I've got to think of a semi-constrained prosthesis. And if it's a type 3 valgus, which is severe osseous deformity as shown right down there, is normally present following a valgus proximal tibial osteotomy or a tibial plateau fracture, I've got to think of more constrained prosthesis. So in a type 1 and 2, this is basically a soft tissue surgery. The method is to release contracted lateral ligaments and structures until the lateral component is balanced with a more lax medial compartment. It normally requires a large polyethylene insert. In a type 3, I'll keep my options open. I have a hinged or a constrained total knee on the shelf. So how do we do a lateral a valgus knee with the bone sections? I tend to do a tibia first compared to a varus knee where I do the femur first. And the reason I do the tibia first in valgus knee is because I want to use the proximal tibia to orient my femoral rotation along with using the Whiteside line. So I use a platform technique. So I cut off the proximal tibia at 0 degrees to the coronal plane or 90 degrees to the anatomical axis. Again, idea is to cut thin to win. So take 6 to 8 of the more intact medial tibial plateau or about 2 to 4 from the lateral. The tibial tray should be sized on the AP dimension of the lateral tibial condyle, but that's the deficient one. You don't want to oversize that. Do the femur second. The distal femoral cut valgus is 3 degrees. No more than 10 millimeters should be resected. So idea is to expect to take more bone laterally on the tibia and less bone laterally on the femur to balance your flexion and extension gaps. So for the extension gap balancing, I think it's important to just focus on soft tissue releases. And we know that in valgus knee, the gap is normally trapezoidal there, and when you extend the knee, well, you have 3 degrees of valgus cut in the femur and 0 degrees in tibia. To stabilize that, what you want is a rectangular extension gap using the inside out or the Runnerworth technique. So what does that involve? Well, I tend to use and remove the peripheral osteophytes, as I've talked about before. Release the PCL completely. This is in type 3 deformities. Release the PCL completely. Release the posterior lateral capsule intra-articularly. So you've opened the joint, you've done your femoral cuts, you've put in a ligament balancer or a distractor, and you've focused on the posterior lateral capsule, and you release that intra-articularly. There. Using electrocautery at the level of tibial surface from PCL, which is right back to the posterior lateral border of the iliotibial band. I think the idea is to use electrocautery because it tends to avoid injuring the peroneal nerve, which in a valgus knee seems to be very close to the iliotibial band, especially once you've corrected the deformity. Preserve the popliteus if possible, and lengthen the ITP using the pry crusting technique. This is again a study by Runnerworth, published in 2004. Now coming on to the flexion gap balancing, that's why bony cuts compared to the extension gap, which is the soft tissue. This is done after the extension gap is balanced. It is done by posterior to anterior femoral osseous resection or cuts. The femoral component is rotation is used using the right side line, not the posterior corner axis, as I've mentioned before. Use the medial and the lateral compartment flexion gap equalization guide to achieve external rotation of the femoral component. So in other words, we've cut the tibia horizontal, we've got the distractor there, we've measured the medial and the lateral gaps and make sure they're balancing or they're equal, and that could orient your rotation along with the Leo right side line. And then you cut the femoral cuts. In summary, the femoral and the tibial cuts are started conservatively. You take as little as you can. Idea is to cut thin to win. Assess the tightness, inflection, and extension. Perform release, especially in type 3 Cracker's deformities, inside-out technique to prevent the damage to the peroneal nerve. Get the femoral rotation right after that, and adapt the operation to the deformity presented. A brief mention finally about the flexion contracture. Well, the etiology is soft tissue contracture of the posterior capsule, gastrocnemius, hamstrings, and the PCL. The interpretive considerations are that the flexion contractures can usually be corrected at the time of surgery by either judicious resection of the bone from femur and tibia, or the stripping of posterior capsule and gastrocnemius from distal femur. Again, as I said, you can remove the PCL and use a posterior stabilized knee. I think we've got to be careful and cautious. Do not dissect large amounts of bone from distal femur, as very often that results in a large flexion gap, which may result in instability in flexion. Of course, be mindful of a popliteal artery. Thank you very much.
One question, the various needs.